All right, everybody. So we're going to go ahead and get into this, and we're going to get talking about sexual health. So we're going to talk about sexual dysfunction in both men and women, and we're going to talk about STIs, so sexually transmitted infections. But before we get started on that, I want to preface this a little bit. So the social construction of illness, which is this idea that we frame and socially construct what it means to be ill, or who and what determines illness. And so in some ways, we take things that are natural parts of our human anatomy, like we do with menstruation, and we turn it into something that denotes illness or denotes abnormalcy. And we'll get into that kind of as we talk about this a little bit more, but it's important to understand that we socially construct what is irregular, what is ill, what is medically normal. And all of those things over the course of time and space have changed, including the status of sexuality and what gets determined as abnormal or what is just varying in sexuality. Sexual health, as defined by the World Health Organization, is a state of physical, emotional, mental, and sexual well-being related to your sexuality. The sexual aversion disorder is where they fear sex and experience a range of feelings from discomfort to disgust, anxiety, and panic at the thought of sexual contact. And this can be due to post-traumatic stress disorder from possibly like a sexual assault, or this could be just something that has come out of your own personality or your in desire to have sexual contact with others. Not everyone that is asexual has sexual aversion disorder. That's a very big thing to distinguish, because there's a difference between just not wanting that or not seeking that out and having severe fear or discomfort surrounding sex. Also note that sexual aversion disorder generally is related to any sexual activity, not just, but it can have distinguishing features of specific only penetrative or something like that if it's tied to trauma. It also has been linked to things like OCD or other anxiety-based disorders, as those things tend to come in congruence with each other. And then persistent sexual arousal disorder, which is the unwanted intrusive genital arousal in the absence of sexual interest, and where even having an orgasm does not relieve the sensation or discomfort. So just to get some of those basic definitions out of the way, when we talk about male sexual dysfunction, the most common form is erectile dysfunction or impotence, more commonly known as. Viagra is generally the medicine that is used to treat that. It is a medicine that I believe came out in the, I can't remember. I want to say it was either the 60s or the 80s, but 20% of men over the age of 20 face this. This is not an abnormal situation, but it is something that we've medicalized because of the links of sexual performance to manhood, to masculinity. And the older one gets, the more likely it is that this will be a regular part of your human anatomy, because we are not supposed to be reproductive beings until the day we die. That's not how human bodies are made. There's differences in attention and treatment between the sexes. So Viagra is something that's inherently very well known. It's something that is easy to obtain. It's something that most healthcare coverage is, almost all healthcare coverage, the treatment for. However, there are some healthcare or some employers and or healthcare coverage packages that will cover treatments for erectile dysfunction, but won't cover birth control or treatments for female reproductive health. So just as a reminder, when we talk about sex, when we talk about it, gender is not binary, and there is sexual dysfunction within gender nonconforming and individuals. However, the research in that is highly limited, and so there is very, very little to nothing said about it, and thus rendered it invisible, which in and of itself is that social construction, again, of what we consider normal or abnormal, and how we frame the kinds of questions that we ask and who is worthy of being asked questions. So as we keep talking about this, and we're going to get into female sexual dysfunction in a second, if you take note, especially if you watch any kind of television that has commercials, which I know a lot of us don't, but even in the streaming services or even in YouTube, sometimes you have those, you're going to see a lot of medicines that are geared towards men, geared towards erectile dysfunction, but very rarely are you going to see medicines in popular like media dealing with female erection and dysfunction. And that's on purpose, right? Because of those links to sexual prowess and masculinity. So sexual dysfunction in women or in females is referred to the medical problem with biological, psychological, or social components, which are age-related and believed to be highly prevalent, affecting anywhere from 30 to 59% of women. And again, they talk about female sexual dysfunction as the inability to maintain moisture, the inability to become aroused, the lack of desire to have sex, the lack of ability to orgasm. And when they talk about these things, there is a drug called Addyi, which is essentially known as the female Viagra. However, it's not covered in the way that in healthcare plans, as in the same ways that Viagra is for men. And it's very interesting the way women qualify for this medical ailment, because a lack of desire can be for a vast number of reasons that has absolutely nothing to do with biological dysfunction. However, there is this assumed understanding that if a female is in a heteronormative relationship, that they should be able to be aroused by that particular man. And instead of questioning the manhood, you're going to question and make a medical ailment for the female that's in that position. And then again, there's links to capitalism and the medical industrial complex, right? So capitalism is driven by females reproducing and making more laborers. And the medical industrial complex is geared towards fixing things. And if they don't have a problem, they can't fix it. And so without essentially making female sexual dysfunction a component, they can't treat it, and then they can't make money off of it. And so instead of really dealing with the psychological or social components that come from, that can come from these different social experiences that women have when it comes to sexuality, such as the extreme amount of unwanted sexual interaction and or sexual assault that happens much more prevalency in women. Instead of dealing with some of those social risk factors or those harms, it is much easier to label a female with sexual dysfunction and then claim that you're just failing your sexuality. Here's a pill, take it and you'll be good to go. And so this is something that we need to remember, that there's a social construction here, and there are social factors that contribute to those things that are maybe not as much talked about for women as are for men. Sexually transmitted infections, or STIs, are a collection of diseases that are transmitted through sexual contact, including vaginal intercourse, oral sex, anal sex, and any non-penetrated genital contact. They're highly prevalent. In the grand scheme of things, most individuals will carry some kind of sexually transmitted infection at some point, or an infection they got via sex, because it is a way in which we trade and interact with others' bodily fluids. This is a widespread of infections, and not just specifically sexually transmitted infections, but infections and viruses more broadly. Women are at a greater risk especially globally, of contracting sexually transmitted infections. Young people make up a large percentage of the new infections, which makes sense because they're less likely to have had it previously and more likely to be sexually active. Intersections of sex or of class, race, and gender also impact these, and their access to sex education and access to understanding how and what transfers these infections will depend on and can depend on who's being taught what and in what ways. So when you have things like sexuality and that intersection of sexuality, there's not a lot in sex education that talks about the LGBTQ plus community. And so there's not a lot of safety that's taught to the LGBTQ plus community when it comes to sexuality and sexual intercourse. Common STIs include syphilis, genital herpes, gonorrhea, chlamydia, and HPV. There are treatments for a good number of these, including antivirals, including an HPV vaccine, and other treatments that limit their impact on an individual's life once contracting these, and possibly cure depending on which one it is. I'm not going to go through and explain to you at a biological level what each one of these things are. However, your book does a pretty good job of showing you the basic symptoms and the basic treatments for each one of these. I will mention that the HPV vaccine is something that you should be able to get at the University Health Center, and it is something that, if you are sexually active, is a highly prevalent STD, and one that the majority of individuals carry or don't. It's one that someone can carry and not know that they have it, because it doesn't always affect everyone in the same ways. And there's a massive amount of different strands of HPV, but it is linked to cervical cancer. And it is something that, if you have the chance to get the vaccine for, it could down the road save you from a lot of heartache and a lot of pain. So there's a lot of stigma surrounding sexually transmitted infections. And there's a lot of shame, a lot of imagery surrounding the idea that someone is damaged or dirty if they have an STI. And it creates something called so your sexual self is an individual self-evaluations of their own sexual desirability and how they think their own imagined and experienced erotic sensuality. However, when you create a stigma surrounding a person's sexuality, such as having an STI, you can have something called a spoiled sexual self, which is the self-loathing characterized by a sense of unattractiveness due to medical conditions, ability, disability, or feeling certain sexual behaviors are immoral. So, and this can come down to a spoiled sexual self can come down to something like sexually transmitted infections, having one of those. It can come down to something like being a member of the LGBTQ plus if you're not in an affirming area. It can come down to you having a physical or a physical disability or being neurodivergent and feeling like there's not a large amount of conversation about sexually active individuals that are like you, things of that nature. So HIV and AIDS, we're going to get into that a little more than we did some of the other ones, because HIV and AIDS has a lot of social components that we can readily access and have conversations about. So HIV is the human immunodeficiency virus, and AIDS is the acquired immunodeficiency syndrome that comes in late stages of having the HIV, having the virus that is HIV. The four ways of transmission, the four most common ways of transmission, is sharing needles with an infected person, sharing bodily fluids via semen, vaginal fluid, or blood with an infected person, a transfusion of infected blood, which happens more at a global level than necessarily in the US, because they have a lot more mechanisms now in place to filter out some of those possibilities. And an untreated mother can infect a newborn during pregnancy, birth, or breastfeeding. So it started like many other viruses in the transfer processing meat from animals. And there is this stigma that it became stigmatized as this gay disease because it was at first it was predominantly found in men who engaged with sex with other men. though it had nothing really to do with one's sexual orientation. It had more to do with the way in, like, the person in which started the virus spread, and the community in which it was first really found in. Moral panic created this homophobic anti-gay rhetoric surrounding this, and religious hate added to that, which allowed for these ideas that God was punishing gays, and that's how individuals got it, and that if you had it, you were automatically queer. However, there were also links to social establishments like the 1960s bathhouses and sexual liberation, and the free love movements that allowed for a rapid transferal within specific kinds of communities, especially within larger populations for those communities. And it did create ways for people to shut down things that allowed social access to sexuality, like the bathhouses. And they pretty much shut down most of the sexual encounters that can happen by taking away the ability for those bathhouses to have individual rooms or individual stalls where people could engage in a sexual activity. And by the 1980s, those pretty much fell out of the wayside anyway. There was an unfounded fear of interacting with HIV plus people in any way, say of hugging, say of being and living in the same houses, and people got excommunicated from families and really got treated really, really badly once becoming HIV positive. And that became, and their unfair treatment even continued in medical facilities. Ruth Coker Burks is an amazing woman who decided that this as a nurse, as she was watching the interactions that the other nurses would have with these individuals, she really didn't like the fact that these individuals were treated in such a different way. And so she ended up essentially taking on being the family and support networks for HIV and AIDS patients. And she ended up burying many of them whose families wouldn't do it or disown them. And she ended up being and caring for lots and lots and lots of HIV plus persons. I mean, she just was a genuinely epic person to read about, to know about in US history. And due to her, there was a movement for essentially within women and within mothers who were taking care of HIV positive people. And that movement and those particular groups are still around. So that's really, really cool. The medical treatment now increases the well-being of patients. So there is a positive spin on this. It is still a pandemic, and access to medical treatment is limited depending on where you are in the globe. But the intersections of identity for those who remain most at risk are really global women. Globally are women who are affected, and in the US it's men, still specifically gay and bi men of color. But again, there's still, with those medical treatments, a long life can still be achieved, and it's getting closer and closer to hopefully finding a cure, which one day we could have. There are social consequences during this crisis. There was there were three really that your book focused on, which I think are good things to consider. And one of which is the retirement of HIV plus positive men as this community specifically ages, and medical treatments create a situation where these individuals can live longer, but will need specific kind of medical care as they age. New drug treatments such as Truvada, we're going to go with that, and prevention style treatments. There's again a cost and an access conversation surrounding all of these medications, which limit the ability for lower income individuals to have them, and or for people of color to have them. And so again, there's a social consequence for having multiple identities and multiple marginalizations. And then women and environmental degradation. The limits on food production puts people at risk for infectious disease. Clean water puts people at risk for infectious disease, and women bear the brunt of these concerns in most of the world globally because they are concerned with the food preparation with acquiring the water in most of the world. All right, so I'm going to stop there, and then I'm going to get on to one more lecture, and we're going to talk about sexuality and disability, and then we're going to be done for this module. As always, if you have any questions, please don't hesitate to reach out and ask, and I will answer them.